And sometimes, yes, there is one thing that is driving a multitude of symptoms, but our bodies are complex. Sometimes it's multiple things like working together that are driving our constellation of symptoms. So then if we have multiple different things occurring in our body, but we didn't find the one root cause, does that mean we didn't find the solution to your problem? I don't think so, right?
Yeah.
And so that's where I feel like it is promising something that really it doesn't deliver.
Welcome to the Wealth Podcast, Off With Your Coat, a podcast on women's health and wellness where we flip the script and ditch the surface level chatter. We need to ask the real questions. Let's get back to storytelling and back to basics to help us uncover how to set ourselves up for true health and wellness and pass it on. I'm Kat Duff, founder of GenWell, the women's health advocacy brand building wealth, the intersection of health and wellness. Some days it's me and a doctor, coat off, talking about what really matters. No fluff, no filters. Other days it's East meets West, trading tools, not punches, to help move women's health forward. We're building generational wealth. Come with us. Coats off, let's go. All right, so today we are welcoming Dr. Basma Faris, a very special guest. She's a board-certified obstetrician and gynecologist and certified culinary medicine specialist. After receiving her medical degree from Jacobs School of Medicine and Biomedical Sciences in 2009, she completed her obstetrics and gynecology residency at Icahn School of Medicine at Mount Sinai. Shout out to New York. Initially a registered dietitian, which is so interesting, Dr. Faris now educates peers on incorporating nutrition into practice and helps patients with women's health and nutrition, something that is so very needed. She runs a telehealth practice for PCOS using culinary medicine and gynecology. In 2022, she joined the Mount Sinai Health System as a laborist and assistant professor in obstetrics, gynecology, and reproductive science. A fellow of the American College of Obstetrics and Gynecology, Dr. Faris also chairs the advisory board to the American College of Culinary Medicine and serves on the PCOS Awareness Association advisory board, advising women health startups. Wow. That is amazing.
That is too much. That
Absolutely
is
incredible.
hearing.
But also, I will add one more thing to that Dr. Faris was actually my OB-GYN when I was in New
Yes.
York. She is such an incredible clinician and someone that empowers women. And I am so delighted to have her on the podcast today as my very first guest. She also delivered my first child, my son, in New York, and also in the middle of the pandemic. So I think that means we're bonded, right?
We are bonded, and it's a special bond. And I love when I can, befriend my patients. It's sort of I don't know. You don't know how it's going to go. And I feel like I do generally have bonds with my patients, but, how to sort of transform that to outside of the office or the exam room sometimes can be tricky. And so I'm so pleased that we are still in touch and that we're doing this.
Well, thank you so much. We're just trying to further women's health and move it forward. And we're just so thankful that you do everything that you do in sort of the nuanced work of PCOS, but in nutrition and obviously laboring now. So what we're doing here is really, it's called Off With Your Coat. So we are encouraging you to take the white coat off and talk to us, woman to woman, girl to girl, just give it to us straight. Your health history, kind of your experience being a woman in this space and sort of even currently what you've been going through. We could start there and then we can dive into some more topics.
Yeah. So I never wanted to be an OBGYN.
Okay.
Even when I was contemplating going to medical school, that wasn't really what I thought I would be doing. I thought I would do something like endocrinology or gastroenterology, something that more directly related to nutrition. But just, I guess, let's back up and let's go to the beginning, which now I realized is like half my life ago, which is really, really crazy. Back to like a different time in which was also sort of like a crisis period,
Mhm.
back to 2001, September 2001, where sort of a weird time. I was here during 9/11. You probably
Mhm.
didn't think this is where that we were going with this, but um, I was diagnosed with endometriosis back
Mhm.
in 2001. I Prior to that, I had had terrible periods, painful periods. And my first gynecologic experience was not a good one. I had a doctor that just told me that's normal, just take the pill,
Mhm.
and no offered no further workup and no explanation. And I hated the pill, so I didn't last on it very long. And
Yeah.
so things didn't get any better, they only got worse over the next couple of years, till the point where, I didn't go seeking help for the pain because I had been told that the pain was normal,
Mhm.
but I would have chest pain. I would have pain underneath my ribs. I would have chest pain that would radiate into my shoulders during my period. And I was like, this is not
This
normal,
is not
right?
normal.
This
Yeah.
is now not normal. So, and I didn't have a good first experience. I didn't even have a gynecologist. I, told a friend of mine, and she said, go to my doctor. She was a primary care doctor, I think a family physician, but she was like, oh, well, she did my pap smear. So I made an
Mhm.
appointment with her. I went, and she was like, oh, this is beyond me. There's definitely something there. I want you to get an ultrasound. And I did. And found these two ginormous ovarian cysts. I remember when they described them, one was the size of an orange and one was the size of a grapefruit. So these
Mhm.
large cysts, I didn't know what they were. I didn't know what endometriosis was at the time. And that doctor, as lovely as she was, gave me a list of gynecologists to call, and I called every doctor on the list, and
Mhm.
nobody would see me, or like the first appointment was 6 months away for a new
Oh my
GYN
gosh.
appointment. And it's like, I'm suffering, and what am I going
Right.
to do? And so early days of the internet, I went on the internet and I said, how can I find a gynecologist who's a surgeon? And that's how I searched. And I miraculously found my amazing doctor, Dr. Melanie Marin, who really was one of the early like pioneers of minimally invasive surgery and endometriosis surgery. So I really just got lucky. And the contrast of the experience with her compared to my other doctors was night and day.
Mhm.
And like, I think really modeled the kind of doctor that I wanted to be. Such a huge difference in the way that she listened to me, in the way that she spoke to me, in the way that she explained things, and then operated on me, and treated me thereafter. And she went on to become, when I went back and became a resident, she had switched hospitals and was at the same hospital. So she ended up becoming a teacher and mentor of mine,
Oh
and
wow.
and now a friend. So it's like, this relationship that she and I have had that spans
Mhm.
over 20 years.
Wow.
But really she is, like, in my mind, the pinnacle
The North
of
Star.
yeah, the North Star of what it
Yeah.
means to be um just like an incredible caring doctor. So when I think of, you asked me before, like, where do
Mhm.
you get your sort of inspiration? And that's one of the places where I get my inspiration in terms of like how to be a better doctor. So from
That's
personal
amazing.
experience, and from, both my negative
Mhm.
experiences and my positive experiences. So
Yeah.
still very, yeah, I get emotional just even like thinking about it.
I
But
love it.
we can't start the hour off with tears. We'll just but at the same
We're all
time,
about yeah.
yeah, no, at the same
No,
time.
go
So
ahead, sorry.
literally on September 11th, I was on my way to my pre-op appointment, my pre-op testing appointment for my surgery
Oh
that was
my gosh.
scheduled the next week. And normally I wouldn't have been going into Manhattan because I lived in Brooklyn, and the hospital
Yeah.
where I was working as a dietitian was in Brooklyn. So I usually either drove or took the bus. So I was on the subway heading into Manhattan to have my pre-op testing, when the attacks happened. And so
Oh
that
my
time
gosh.
is really sort of layered on top of each other for me.
Mhm.
It was such a
Mhm.
weird time, but I remember when, when everything was unfolding and they were calling for volunteers and healthcare workers, and even though there weren't any people really to care for, sadly,
Mhm.
I do remember feeling like, God, I feel so like powerless. I'm a
Yeah.
dietitian. Like, what can I do in this
Right.
scenario? Not that
Right.
my work wasn't valuable, but I definitely remember feeling this like this draw to like want to be able to pitch in. And I was like, I don't have any skills that would allow me to sort of help in case of an emergency. And so that was happening around the same time. And so,
Mhm.
I think major life events often really force us to take a look in the mirror and just sort of take a look around and decide what we want to do with our life and what our lives should look like. So that was sort of all happening when I decided to make a change and go to medical school.
I love it. Oh, similarly, and we had talked about this when I was postpartum with Carter, it was also during the pandemic. And so obviously different circumstances, but that is sort of what led me to start questioning more in depth just the system. And not that I can fix the system, but just how do we empower women to start asking the harder questions, to be the
Yeah.
squeaky wheel? Um, I would come in with my CVS receipt sized scroll to your appointments of questions and, ultimately say, apologizing for having all of these questions. And I just recall you being, you know, your response was always, don't be sorry. These are the things that you need to ask. And these are the types of questions that you need to, understand to understand what's happening. And for me, like my nuance, I have PMDD. I was working with a psychiatrist. I also, I'm very much like Eastern and Western medicine. So I was working with a naturopath. And I think in that moment of postpartum, and you were so wonderful to work with from, fertility to birthing to postpartum, it just really got me leaning into, okay, how do we do more? How do we educate women more? How do we sift through the bullshit? Like you are, I mean, again, another shout out to New York. Thank God for the no bullshit approaches that everyone has. But I think that really was eye opening for me in that time where I wanted to make a shift and really lean in. And so it's just really interesting that we had those kinds of like epiphanies. So tell me then, so dietitian to then going to medical school,
Yeah.
what was that shift like?
Um, it was harder than I thought it would be. I thought I would be able to lean a little bit more
Mhm.
on my knowledge
Yeah.
and my skill set,
Mhm.
and found sometimes that that wasn't the case. I remember they wanted us to learn how to talk to patients
Mhm.
in this very specific way, right? And I was like, I know how to talk to patients. Like,
Yeah.
if anything, that's all I do.
Right.
And I remember when I was looking because they posted the grades up.
Mhm.
And, I started off looking at, and they, by order of like grade, with the highest grade at the top. So I started off looking at the top of the list, and like I was, found myself like scrolling down to like the
You're like,
lower
"Oh,
third
shit."
to find my grade, and I was like, oh shit, like what? Like what? How is that
Yeah.
even
Yeah.
possible? If there's
Mhm.
one thing that I know, right, that I
Yeah.
felt like I had an advantage
Right.
over some of my classmates who were fresh out of college, I was like, that is it.
Mhm.
And but it wasn't the way in which they wanted. So
So what was the way that you were doing it versus what they were trying to get you to do in med school?
yeah, they wanted us to ask like questions in a way that was in a particular order. Um
Mhm.
Open-ended questions so that you could allow people to talk things that make sense, and I think things that I do. But, I guess I wasn't just hitting the check boxes of the things that they were looking for. And we
Mhm.
used to actually have to take an exam called the clinical skill step, part of step 2, clinical skills, where we would go to these testing centers. I went to one
Mhm.
in California. I think there were like 4 maybe across the country with like simulated patients to have these interactions, and they would grade
Wow.
us on this very strict rubric. I don't think it exists in exactly the same way anymore, but that was
Yeah.
part of our, progress through the step exams, and so that's what they were preparing us for, this
Hmm.
exam, which was really awkward in the way in which, and I'm glad they did away with it because I felt like the way that they were teaching us to communicate was not
Too
not
rigid?
yeah, too just,
Yeah.
I don't know, sort of uncomfortable. I get maybe for people who really are shy, introverted, or maybe people, from other countries for whom
Mhm.
English is not their first language, so
Right,
coming from
right.
different cultures, how maybe that would be a beneficial exercise, but it certainly, anyway, wasn't for me. And you know what? I didn't change. I didn't change the way I talk to
Yeah.
patients because why should I?
Which is,
So I just learned how
yeah.
to talk to them, for the test, and but I had to like learn that. So that, that was definitely different.
Mhm.
And I just didn't really find my people. Even in the endocrinology department, I didn't find people that were that interested in my background, which really sort
Yeah.
of surprised me. I think that's changed a little bit, especially where I went to medical school. I think they now have like a culinary medicine program. They certainly didn't when I was there. I
Yeah.
was the only person that gave a nutrition lecture. I volunteered to give a lecture to my class and one of the other classes either above or below me, and to some of the
Mhm.
residency programs on basically how to screen and talk to patients about nutrition. So but nobody else was doing that.
Wow.
So that was definitely different, definitely a different experience.
Why do you think that doctors are not trained in nutrition in an extensive way?
Yeah, I mean, that goes back, I think it's like 100 years now, with the way that they changed the curriculum and decided what was important, and just decided that wasn't relevant to the modern medicine curriculum. And
Mhm.
so, that's changing. Hopefully, there are calls to introduce more nutrition into the medical education, not in a way that makes physicians experts at nutrition, but
Mhm.
just to allow them to understand some more nuance and be a bit more proficient and screen
Mhm.
people for, um, you know, eating behaviors that may not be optimal. And so to help, and
Mhm.
then to hopefully help refer to people who can help them even more.
Right.
So I think that certainly makes a lot of sense. But
Yeah. I mean,
yeah.
you're a North Star in that regard. I think just having both backgrounds is so different. And I remember being in your care talking about, prenatals, which is a hot button topic that we'll have to get into.
Mm.
But just in that regard of just being so lost in like folic acid versus folate and do I have the MTHFR gene and just diving into things that we should be understanding, but also, should you be getting some of these nutrients from food at the get-go?
Yeah.
And not just for fertility, but you obviously are so versed in that with PCOS. So um, when we are, advocating for our own health, I know we've been talking a lot about how do we create this sort of village of clinicians or practitioners around us. And how have you found your own outside of your mentor, your own physicians and people that you trust? Are there things that you look for, questions that you ask to sort of get to the best people?
I'm lucky in that I get to interact with so many different clinicians.
Mhm.
And so I really can get the scoop on
Mhm.
who's good and who isn't good,
Yeah.
in a way that the public can't. And sometimes
Mhm.
people who are very successful and popular maybe aren't actually the best at what they do. They're just good at
Yeah.
promotion, or they're just very
Mhm.
good socially. They're good at networking.
Mhm.
Or there's sometimes are people who hold these prestigious roles within an academic institution
Yeah.
that I think to the lay public would imply to them that they are very good, let's say surgically. and maybe they're
Mhm.
not
Mhm.
necessarily.
Mhm.
So that is sort of tricky. And how do you, as a non doctor, non healthcare
Mhm.
professional, figure that out? I think
Right.
it's really just from talking to people, talking to other people who have experienced what you are about to
Mhm.
experience,
Mm.
to get a sense of both bedside manner and proficiency, which are both really important. Because you can have
Yes.
somebody that's really skilled and really proficient, but if they're an asshole and they can't talk to you, you're not going to feel safe in their care,
Right.
right? You're not going to feel psychologically safe, but
Right.
you don't really have a way of assessing how they are procedurally
Mhm. Mhm.
because you just don't, unless you talk to a lot of people who have had the same procedure and you can get a
Right.
sense of their success rates and their complication rates. And
Mhm.
so it's important that you kind of, do both. And thankfully, there are reviews and there are chat groups and there's Reddit and there's so many different ways that you can do that now,
Yeah.
that you can really get a sense.
Yeah.
If people are having a lot, because what do people do? People post when they're the most unhappy about something, right?
Mhm.
If people are generally satisfied, but not overwhelmingly so, they're not going to say anything. So
Right.
people are either most likely to post things when they're unhappy or to like the extremely, extremely satisfied.
Right.
So you can still get a sense, by checking, what's out there and what people are
Right.
saying in their reviews. But talking to as many people as possible. And that's where I think communities are so powerful, especially
Mhm.
online communities. If you have a particular condition,
Mhm.
um, that can be a really great source of finding recommendations.
For sure. I think it's so hard for women because we move so far away from trusting our own intuition that we're looking for, we weren't really taught about our bodies from the get-go. And so we're sort of pulling at straws. It's like we want to find someone that we trust. And what does that look like? Is it, to your point, someone who has good bedside manner? But I personally look for doctors that I can have a relationship with because it's so important to me to be able to not that I won't text you all the time, but I do about personal things and what's going on because I develop that trust over time,
Yeah,
and it is very hard. I think in the mental health space, uh, it's more talked about where, oh well, it takes a while to get to the right therapist or the right psychiatrist, but it's not really talked about in general medicine or the OB/GYN
yeah,
world. And that I think the same thing applies. It's like you don't need to latch on to one doctor just because someone says so. You might have a completely different set of nuances with your own health. And what works for one doesn't work for the other. Like I love a no bullshit approach. Someone might be put off by that. I think, in our experience specifically, and this is maybe with something we can talk about for the OB part of things is obviously in many hospitals, there is a rotation aspect for
yeah,
laboring. And in our scenario, there was one doctor that reminded me very much of Miss Trunchbull from Matilda, and I was not very comfortable. So I recall when we were, going through the process and, I was like, I don't want a formal induction, but we did do a membrane sweep. And I'm like, what night are you working? Okay, great. How can we get as close to that as possible? But that is a real thing. It's like you
yeah,
have this trust, especially in that intimate moment. And now with, I feel like we also spoke about just the mistrust in obstetrics in general,
yeah,
which is pretty low, right?
yeah. Or yeah, the trust is low. Yeah,
The
for sure.
trust is low. And is that because of this rotational aspect? Is it because of the trauma of birth or just that transactional nature of it? Or where do you think that comes from?
Yeah. I think to your first point, I think you're right. People like different approaches. And so I have a saying that I've sort of come into,
Yeah.
maybe in the last 10 years is that I'm not for everybody and everybody's not for me, right? I get
Yeah.
along with most people.
Yeah.
I think I'm a pretty easy to get along with person, but sometimes
Mhm.
you don't click with it for whatever
Right.
reason, right? And
Right.
that's okay. And you
hmm
don't have to try to change or to make it work. You don't have to
Right.
please people. It's
hmm
just for whatever it just isn't, right? It's just not
Right.
working. The trust issue is so layered. There's so many real reasons for that to occur, because there have been historically, the sort of paternalism, real examples of trauma. So there are real reasons for the trust to be eroded. There are challenges within the system of rotating and maybe not being able to get to know your doctor, or you may be attended by somebody else who you don't really know as well, so you're not able to develop that. And that's a challenge of our system, and the how we're reimbursed as
Right.
obstetricians, and the lifestyles that we also need to have. And then there is a lot of things that I think have gotten in the way. I think this is an area where social media has not made things better. If anything, probably have made things worse.
Right.
Again, people only post their bad experiences, and we as obstetricians are really not allowed at all to tell our side. There is not a forum for us to be able to sort of explain. It's really a challenging place to be in, I think, for all obstetricians, because you can see both sides, and sometimes people not understanding that their sort of their wishes and their plans when it comes to their obstetrical care and their birth are really at odds with good outcomes. And we can't ever say that, right? We have a burden to provide a perfect outcome and a perfect experience. But we can never then, on the flip side, say, hey, your choices that you are making as a parent are actually harmful, right? That would never be an acceptable real conversation or statement. And we certainly could never make that publicly. And so it really just leads up to this very unfair dynamic that I think that plays out in the public, that we really have this. Every obstetrician that I know wants the best outcome for their patients. They want their patients to come through their birth safely, and they want the baby to come through the birth safely, and hopefully they're getting through this without it being emotionally difficult or traumatic. That is what we all want. But what makes something traumatic for one person and what makes something traumatic for somebody else also is subjective, right? So one person's trauma, other person's like, oh yeah, that was no big deal. It just was what it was. It was sort of an intense situation, but we're fine. And so I think there are all those different layers that make it challenging. And then how to reconcile that, though, that's what we don't do a great job of, is the after, like the day after and the aftermath. And I think if we had a better way for people to then reconcile their experiences, either with their clinician, their obstetrician or midwife, or with somebody else, I think that would be really powerful for people then to be able to understand, this was an emergency, and this is sort of normal for that emergency, and this is what could have happened if we didn't act in that way. Or no, this really could have been done in a different way, and your instincts are right. Or, something sort of in the middle, right? And so to let people understand their experience and what happened, I think would be really powerful. And I don't think we really have a good way of doing that.
Yeah. And I think it from the proactive standpoint too, to your point earlier of like, we can't share, that's because of HIPAA, or that's like in general, obviously you can't share personal stories, but is there any way that you think, so for example, like I've had friends that have had horrible hemorrhaging that they weren't prepared for, or circumstances where, they were laboring for a long period of time. And so another obstetrician had to sort of tag in and,
Yes.
or, leave, and they were feeling like they were forced into something that they didn't want to be in. And
Yeah.
so I think I never had a birth plan, and we had talked about that because I had ideas of things that I would like. Like I wanted to labor at home for as long as possible because I didn't want to have to deliver in a mask. And then I labored at home for 11 hours with back labor, and then I was only 4 centimeters. So I got the epidural and we were golden. But I'm of the mindset of you can plan and have ideas, but you can't have that full plan.
Yeah.
But are there ways that we can ask questions ahead of time with our, care team before birth so that we understand sort of the cost benefit of things that might happen in birth? And I understand we don't want to fearmonger, but there are real consequences to birth. And there are things where sometimes we need that dose of reality so that we can stay the course when someone of I hate to say authority, but someone in that role who is our caretaker at that very moment and of our baby, that we can say, okay, we trust you, let's do this, versus
Yeah.
pushing back and maybe delaying something or fighting that care.
Yeah. Yes, as many discussions as you can have beforehand
Mm-hmm.
are, are going to be helpful, right?
Mm-hmm.
You can't plan for every single scenario.
Right.
But if you, for example, develop preeclampsia and need to have an induction,
Mm-hmm.
right? But an induction was never in your plan, right? That's different from an elective
Right.
induction. And
Right.
now you have to readjust your
Mhm.
expectations.
Mm-hmm. Mm-hmm.
And if you're going to then agree with the induction, then you should also agree with all the methods of induction, right? It's not
Right.
like, I'll have fries with that.
Mm-hmm.
There's a
Mm-hmm.
way that makes sense that's going to be more effective. And
Mm-hmm.
oftentimes we're having to negotiate those things, which ultimately lead to worse outcomes, longer labors, infections, stuff like that. And so, but you can't then after the fact be like, when patients will ask, well, how come this happened? How come my labor stalled? How come I ended up with a C-section?
Right.
Like, as an obstetrician, it's poor form to be like, well, yeah, you chose to not, like, you refused to accept this, and
Right.
that's why we're in this scenario. Even though that might be the truth, I would never say that. And I don't know
Right.
anybody
Right.
else who would ever say that. And it's not helpful because you can't change
Mhm.
the outcome at that point.
Right.
But, we feel that sometimes. And
Yeah.
so, but we bear the responsibility, even though we maybe weren't, even though we maybe made a recommendation that our patients
Mhm.
didn't like.
It's a tough position.
It's a tough position. It's a
Yeah.
really tough position.
Right.
And I think that goes to erode the trust.
Yeah.
What I like to, and this is an approach I try to take whenever possible, if people will ask me, well, what if we do this? Or how about this? Right? Instead of saying, no, you should do it this way,
Mhm.
I'd say, yes, you can do it that way.
Mhm.
And this is how it will differ from the way that I'm recommending.
Right.
And so it's not to tell people no. People don't want to hear no.
Mhm.
And, these are the pros and these are the cons. And yes, you might be like, you are right about X, but maybe you didn't know about Y. So let
Right.
me fill you in about the flip side. And that's, I feel like, my responsibility. I think people feel much better when they've come to the same conclusion,
Mhm.
when
Mhm.
they have more information. I think people
Right.
feel better about those
Mhm.
decisions than instead being forced, feel like they're being forced into something that they didn't want. And
100%.
so, that's just a different
Mhm.
way of communicating.
That's why you failed your test, because you
Right.
were it's because that's what you were asking the right questions. And I think we just, as women, need to dig deeper. We need to get to the right practitioners that are asking those questions and helping us uncover that. I mean, on our end, we need to do the due diligence to come prepared with questions, to research, to do all those things, to sift through the bullshit on social media. And that's another actual great segue of
Yeah.
now with social media, and I've done this before as well. I tell my husband all the time, like, you're raising my cortisol. And who knows if that's true or not, but we are coming to doctors already, with our own diagnosis in mind. On a
Yeah.
given day, because of social media, I could have ADHD, POTS, I could have COVID, perimenopause, all of the things at once. And so how do we not do that? And I guess, what does that do if I were to come to you with my own
Yeah.
diagnosis? How does that hinder your practice with me?
I don't know if it necessarily hinders it, but
Yeah.
I've had to adjust the way then I communicate, right? So if
Mhm.
somebody says to me, which is often in my PCOS practice, I'm having a lot of inflammation,
Mhm.
right? And that may or may not be true, but what I need to then do is get to the bottom of why do they feel that that is what it is,
Right.
right? What does
I'm
that
laughing because
mean to
I feel that
you?
right now.
What do you mean by that? Right? What do
Mhm.
you mean by you have a lot of inflammation? And the answers are
Mhm.
all over the map. So for some people, it's like, I'm having hives, right? Yeah, that's definitely an
Okay.
inflammatory
Yeah.
response, right?
Mhm.
For somebody else's, I'm having bloating. Well,
Mhm. Mhm.
maybe, right? Is that just,
Mhm.
is that gas? Are you constipated, right? That's a
Right.
completely different
Right.
process that's happening. I'm having joint pain. Yeah, that could be an inflammatory process. So then it's sort of, what are you, really, what are your symptoms? Let's not go down a predetermined rabbit hole.
Mhm.
Let's rewind, take a step back, and make sure that we're not missing something by
Mhm.
really understanding what it is. Because, yeah, everybody does their research beforehand and they've sort of come up with their diagnosis,
Yeah.
which isn't necessarily bad, because then to me, I feel like, well, I know that you are proactive and you're going to go. And if I give you some homework and I want you to
Yeah.
learn about things, then you're going to go
Mhm.
learn about things, but you're going to go learn about the right things.
Yeah. So when you are offering tools in this new world of many hats that you're wearing, so
Yeah.
the culinary medicine side and telehealth, and it feels, and correct me if I'm wrong, but you are really straddling that Eastern Western medicine side, where I would say just more integrated
Yeah.
medicine,
I
which,
don't think of it that way, to be
okay, tell me.
honest. And this is sort of where there's one of those like hills I'll die on. Um, I do practice in a way that is holistic, and
Okay.
holistic meaning whole body, whole
Mhm. Mhm.
experience, right? So we're not just talking physical, we're talking emotional, psychological,
Yeah.
spiritual. So a whole body way of practicing. Nutrition, right? A lot of times what I don't like is nutrition gets lumped
Mhm.
into alternative,
Mhm.
um, Eastern, whatever term you want to use.
Yeah.
Nutrition is a real science.
Mhm.
It's a real science. It's a real discipline that I have 2 degrees in, and so I am defensive of it in that way. And there is legitimate evidence to make recommendations.
Mhm.
They are different, maybe, from sort of traditional, meaning Western conventional medicine,
Mhm.
in that the studies and the type of evidence that are used are different from, let's say, a randomized controlled trial that we
Mhm.
use for medications. And so
Yeah.
that's a lot of times what people, physicians, many physicians will argue, that the evidence around nutrition recommendations is not as solid or strong because there aren't randomized controlled trials. But you
Right.
can't really conduct nutrition research in that way.
Right.
So that means we need much more evidence, and that may be smaller intervention trials, that may be larger epidemiologic studies, that may be bench science looking at mechanisms, and you put all of that together and you
Yeah.
make recommendations based on the best information that you have.
Mm-hmm.
And so it is a different way of interpreting data and a different way of making recommendations based on data, but it's not lesser. And that's
Right.
been sort of why nutrition is dismissed. At the same time, it's about food, and food is very personal,
Mm-hmm.
and there's so many different cultural nuances to food. And so it opens the door for a lot of people to enter it who don't really know the science.
Right.
So a lot of people can make recommendations, and they may be right most of the time, but oftentimes aren't understanding why.
Right.
And so either for recommending something or recommending against something.
Mm-hmm.
And that to me is very frustrating. So I think
Mm-hmm.
it's incumbent on those of us who have some real, nutrition knowledge, to step in and
Right.
make sense of it. And a lot of times it's nuanced. People
Mm-hmm.
don't like nuance,
But it's necessary
right?
in everything.
Yeah, but it's
Yeah.
not, it doesn't make for viral videos and doesn't sell things. So
Right.
yeah,
Well, I mean, but that's exactly what it is. It's like the nutrition piece is it's back to basics. I find, and again, I have found a really good groove for myself in, having a naturopath and traditional medicine, and I respect both disciplines, but I also have to play that role in advocating. So to your point, sometimes, I've seen practitioners where I'm like, those are too many tests, or you're giving me like 80 batteries of tests, and that's too much information for me. And also as a woman, it's one snapshot of my hormones. It's one snapshot in time. And so it's really like we have to become these discerning consumers and
yeah,
patients all at the same time, which is really tricky and
it
something that
is
I'm
really
hoping that we
tricky.
can at Genwell like really push for
I
as a
think the
learning.
I think the best question that you can
Yeah.
ask your practitioner
Mm-hmm.
to try and determine if something is needed or not
Mm-hmm.
is is that information that you are going to get from this test that you are recommending, is that going to change your recommendations
Mm-hmm.
in
Mm-hmm.
any meaningful way?
Right. Right.
Because if it's not, if you're going to tell me the same thing based on the symptoms and the tests that we've already done, why the
Mm-hmm.
fuck
Mm-hmm.
am I going to go do
Right.
this?
Right.
Spend the money, spend the
Right.
time, spend the anxiety waiting for the
Mm-hmm.
results. Why? Why would you do that?
Right.
And
Well, that's
so,
yeah.
yeah.
That's I mean,
Ev-
the whole mental health piece too of just the
yeah.
anxiety of, oh my gosh, I have like an indicator that's telling me I'm going to have a cardiac event, and then no one's sitting with you. There's so many direct to consumer brands now,
Yeah.
and unfortunately some that are spearheaded by actual physicians.
Yep.
But a lot of these, and in my background in media and advertising, I've seen how so many brands and companies are preying on women in that way. I mean, everyone, but predominantly women in a very specific way. And it's like you get this battery of tests, and then no one's giving you any information about how to, outside of maybe their own bundle of supplements,
Right.
where you don't know if they're being absorbed or, so that
Yeah.
is
You don't know if something's actually wrong with you or not.
right,
And that to me is just like, that's just terrible. Right.
right.
Um, it's very frustrating for me. Every time I make a plan with a patient, I will say, these are the things, this is what we know, right, so
Mhm,
far.
mhm.
And
Yeah.
we can investigate it further. But if I really don't think, and I'll gauge, like sometimes people are like, no, I have to, like, I absolutely have to know. Or some people will be like, I'm willing to hedge my bets that what you're saying is probably true, and we'll
Yeah.
make some adjustments and we'll see if I feel better, right? Which is a valid approach as well.
Right.
People don't sort of forget that sometimes there's value in testing different tweaks and seeing if that makes you feel better. That's as
Right.
powerful as this, deep dive root cause approach, um, because you've tested it, right? You've actually, that's a test in and of itself. And so I think that's really valuable, and we forget the value in that. So if something's going to only add maybe another percent or two of certainty from what we already suspect, some people will say, yeah, I need that certainty. And some
Yeah.
people will say, no, I think what you are saying sounds and feels like that's what the truth is. And I'm okay with that.
So how do you feel? Well, one, I would like to ask you, because I know you hate the term root cause.
Yeah.
So is it the inherent understanding of what a root cause is, or give me the quick and dirty on
I feel like
what
it's
you
a
think.
false promise,
Yeah.
right? That we are going to somehow find, because to me, root cause means we're going to figure out if there's a gene mutation that you have that is present in these cells of your body that is
Right.
functioning in this way that is making you feel the way you feel,
Right.
right? And that after we do that, we're going to be able to also find the targeted treatment for that root cause. But that's not what is happening, right? Our testing is only good as the tests that we have. And so by most of the time, it's not that. And sometimes, yes, there is one thing that is driving a multitude of symptoms, but our bodies are complex. Sometimes it's multiple things like working together that are driving our constellation of symptoms. So then if we have multiple different things occurring in our body, but we didn't find the one root cause, does that mean we didn't find the solution to your problem? I don't think so, right?
Yeah.
And so that's where I feel like it is promising something that really it doesn't deliver, if that
So I
makes
think,
sense.
yeah, I think where women in general, I think, are getting frustrated is we're kind of a similar scenario where you felt someone was just giving you a Band-Aid, a catch-all with birth control, right? So again, not everyone does that, but there is that essence of like, okay, let's use a pharmaceutical or a quick fix tool and not really address something deeper. And you do a great job of addressing that, as we were talking about before, in the questioning with patients. So what can you say to women who are curious? So say I have these, battery of symptoms, someone's putting me on prednisone or something to kind of Band-Aid. How do you seek out that additional support to identify what those other challenges, or to your point earlier, what that test and learn for you might be?
Yeah. Yeah. And sometimes, it's looking at what has been done already. Is the diagnosis really clear? Right? If it's not, then maybe we need to dive a little bit deeper, do a little bit more testing. If the diagnosis is really clear and fits your pattern of symptoms, have we explored all of the different options? That's the next level of conversation. Or did somebody just give you one option and say that that's really the only option, and they didn't really explain to you, and you don't feel comfortable with that treatment option, and they didn't explain to you why? Right? So case in point, I told you about my experience with my first gynecologist who didn't explain to me that there could be something wrong with me and just told me to go on the birth control pill, which I hated, right? When I was diagnosed with endometriosis and after having my surgery, my doctor said, I think you should go back on the pill. You're not planning on pregnancy anytime soon. And you should go on the pill. And I was like, I really hate it. And she was like, well, this is why. This is what could happen if you don't. These are the alternatives. And then lastly, let's figure out there are other options. So if you hated the one that you were on, let's try to work together to find one that you don't hate. So I did find one that I didn't hate. I didn't love it, but intellectually, I understood why it was important, and that made all the difference. So I was able to, what I was able to tolerate as a side effect was different because of the knowledge that I had and that process that she and I went through together.
That's such
Didn't
an
take
important
that long,
distinction.
right?
Yeah.
It's such an important distinction. And so understanding what your options are, understanding why that your doctor thinks this is the best solution for you. What are the alternatives? Can you try something else first? And if that doesn't work, come back. So what are the pros and cons is a totally different conversation than, that message. This is your test result. Here, I'm sending you a prescription to your pharmacy, right? Without a conversation.
So what would you say to someone? Oh, sorry, go ahead.
Nope, that's it. Go ahead.
So what would you say to someone like me then who is like, okay, I'm doing my own research. I'm very interested in just sort of learning about my body. And we know that the gut microbiome is so important, and we don't know everything about it, but like, how can women actually work with other modalities with traditional medicine? So if we are working with an acupuncturist or a naturopath or other modalities, is there a way to triangulate best with traditional medicine?
Yeah, I think that's very important, to be able to, you have a doctor that's open to say, yeah, there's nothing wrong with you trying that. And you can try it first, or you can try it alongside of this other treatment that I think would be beneficial to you. And so you can sort of decide instead of somebody saying, yeah, no, you shouldn't do that. And then that turns you off and you decide, well, I'm just going to go the acupuncture route and I'm not going to take that medication and I'm not going to go back to that doctor. And maybe that medication really was important, but you weren't convinced. And now that therapeutic relationship really has not, hasn't been enhanced. And so, so as long as somebody's not dismissive of you and they may not believe in it, but that doesn't mean that it's going to harm you.
Right.
Right.
That's my personal thing. Yeah.
Like, why do you, if it helps you, that's amazing. And if you don't understand it or don't believe in it as a doctor, that's fine too. But there's no reason that you have to dismiss your patient and what they want to try. I think that's disrespectful.
Right. Do you believe in gut tests as medicine stands now?
I wish. I wish I could say I did. Right. I mean, a gut test is going to tell you about a bunch of different species that are growing in your gut. They're not going to tell you necessarily about how to really fine tune it and adjust it to improve your specific condition. So that's what I wish, right? We know, for example, people ask me this all the time, like for PCOS, we know that people with PCOS have less diverse microbiomes and they have fewer gut bacteria. And there are some patterns of bacteria that are associated with PCOS.
Interesting.
And you could probably say this for hundreds and hundreds of conditions. We know that there are patterns, okay? That doesn't mean that we know exactly how to shift those patterns and what is the consequence. Because you may improve one condition. Are you making a different condition worse?
Oh, that's
And so
interesting.
sometimes there's a pattern that maybe is more associated with one condition, but a different pattern is associated more with a different condition. So we don't have that level of sophistication. I really, really wish we did, because I do recognize the importance of having a healthy gut microbiome, but I don't think we really are there yet. So I support the research. I support the concept. supporting your gut bacteria, right, by your nutrition. But I wish we really had like, yeah, this probiotic is going to make a huge difference in your, disease symptomatology, whatever that condition may be. But we're not.
So do you,
Aside from like
yeah,
stool transplants,
what is a stool
where
transplant?
oh, yeah, that's a real thing. So,
Okay.
I
Tell me
first learned
more.
about it when I was in medical school, and they're only used really for, um, people with severe, gastrointestinal infections and diseases that are refractory to other treatments. So if somebody has an inflammatory bowel disease or
Wow.
they've had a C. diff infection, like something that really has disrupted the lining of their intestines, they will actually administer stool from somebody else into that person's intestine.
Wow.
Yeah, that's a real treatment. It's not a
Okay.
treatment for PCOS, for example,
Or the
right?
faint of heart, I
Or
think.
the faint of heart, right? It is a real, so it's really like an extreme treatment for
Yeah.
some extreme conditions. So I say that sort of in
Interesting.
jest, but
Yeah.
it is actually a thing because
Yeah.
we know that certain patterns of gut flora are
Mhm.
associated with disease and lack thereof. So in
Yeah.
some extreme conditions, it is used as a treatment.
Is there in your PCOS practice as well, obviously there's probably a different direction, but in terms of probiotics
Yeah.
in general,
Yeah, I
what do you
think
think of
they're
them?
um you know getting enough of the lactobacillus species and
Mhm.
bifida species, which are easy to
Mhm.
acquire in lots of fermented foods,
Mhm.
has been shown to shift the microbiome in a positive way. And so I do think, generally speaking, fermented foods do better at helping
Mhm.
your gut microbiome. And that's what studies show over
Mhm.
supplements that oftentimes get digested or, just damaged by the acidic environment of our stomach or the basic environment of our intestines. And so by the time, it reaches the large intestine, all the bacteria are dead.
Yeah.
So, so certainly if people are not consuming any naturally, any fermented foods, it's definitely something that we try to work
Yeah.
on. Absolutely. So, but there's not like a go-to supplement that I recommend. And it's not because I haven't tried. I've tried them myself and I've
Mhm.
recommended them in the
Mhm.
past, but then, I haven't had people come back and be like, yeah, I've really noticed a big difference.
Mhm.
So if I, in my experience, haven't had a number of people really find that there's been a big improvement in their health, I can't, with good
Mhm.
conscience, keep recommending it.
Right. So this brings me to uh sort of one last point of these like hot button topics on social media that I'd love to
Yeah.
just address with you. But um when, you know, women are trying these different things online, if it's like a trend or what have you, what is sort of the from a supplement perspective, if I'm taking magnesium, if I'm taking a probiotic, like are there other blood tests I should be taking in tandem with that so that I have a control or I have someone that's overseeing what I'm doing?
Um, by and large, probably not. For many
Okay.
supplements, we don't have
Mhm.
good values to determine if you have a deficiency.
Mhm.
Now, certainly that's not the case for, we can test for vitamin D, we can test
Mhm.
for ferritin, to test iron stores, we can test for folate and B12. So there certainly are some vitamins that we can test for deficiencies.
Yeah.
Things like magnesium, usually not, because it's a
Mhm.
very controlled, the values of these smaller molecules are pretty tightly
Mhm.
regulated. And
Yeah.
so even if you don't have great tissue stores, your blood test is going to come back normal. And so it's really sort of the, if you feel it's something that might be helpful to you and you find a good source,
Mhm.
a good reputable brand, and if you try it and you feel better, then
Mhm.
great. It doesn't cause you any negative side
No harm, no
effects,
foul. Yeah.
then great.
Mhm.
Um, supplements, there is real concern about safety.
Mhm.
Um, it's one of the leading cause of liver damage in this country,
It's wild.
but it isn't, right? We're talking about an
Mhm.
unregulated industry, and who
Mhm.
knows what's in them.
Right.
And so many people, even if it's a
Mhm.
brand that you think you trust or a clinician who you think you trust, they're not producing it,
Mhm.
right? They're white labeled. So you
Right.
don't really know, are they skimping, right? Are they trying to
Right.
increase their profit margin? Uh, you
Well, the
really don't
additives,
know.
the plastics, like
You
everything
really don't
else that's
know,
in
right?
there.
They put there's lead in them, there's
Yeah.
other adulterants, or sometimes they don't contain what they say they contain. So,
Right.
it is if you are really relying on supplements for your health, that's a problem. That's a
That's
big
a great
problem.
point.
Supplements are it's in the name.
Mhm.
It's supplemental, right? It's not supposed to replace or provide your only source of those
Right.
nutrients. It's
Right.
supplemental.
Right. Go back to the nutrition. Get it
Yeah.
in that way. So, I know you love this one, but when women come to you or you see an amazing influencer on social media saying, "Hey, I can balance your hormones." What do you say to that?
You know how many hormones we have?
Me? No, I'm a layman. I do not know. So
Six
tell me.
it's about I think it's 60.
And so we can balance them all? Wow. With one
Right?
pill or
With
a
one
coaching program?
pill or a coaching program, right? So my answer always is which hormones in which direction,
Mhm.
right? I mean, what the fuck does that even mean? It drives me insane, insane. And it sort of diminishes that some people really do have hormonal imbalances, and those are
Mhm.
medical conditions, and
Mhm.
they need to be identified and treated appropriately and not overtreated and
Mhm.
not undertreated. And so, that's really, yeah, it, it,
So
it
how
it
do you
definitely hits a
identify it?
nerve.
Yeah.
Usually, yeah, it's usually blood tests. Sometimes it's a one-time static blood test. Sometimes it's timed or
Mhm.
in relation to something else, to a trigger. So for the adrenal glands, sometimes you have to suppress them. It's called dexamethasone suppression test to see what happens. To test for insulin resistance, a glucose challenge, right? Like it's similar to the gestational diabetes test, right?
Right.
You see what
Mhm.
happens when you give the body a challenge of a glucose load. And so, you have to identify and you have to treat it appropriately. And oftentimes, there may be a mimic of a different hormonal condition because these different hormones interact with each other. And so,
Mhm.
if you think you have PCOS, but actually you have a thyroid disorder that you are not treating because either it hasn't been identified, hasn't been diagnosed because you did some panel but you missed your thyroid testing, well, then that's not PCOS. You have to correct that first.
Right.
You
Mhm.
can't identify it if your thyroid is abnormal. You have to correct that
Mhm.
first, and then you go back
Mhm.
and you retest. And so
Right.
that's really important. And it can be dangerous. And I'll see people, and they'll be like, "Oh, I have PCOS and I have hypothyroidism," and they don't want to take anything they want to do everything naturally, and they don't want to take thyroid replacement, which is
Mhm.
that's like really harmful. Um, and they think they have another condition which they may not actually have because they aren't correcting the first one, right? And
Interesting.
because they
Yeah.
thought somebody told them they could balance their fucking hormones. They can't. So,
Oh, and a powder
and
too.
that right? And it's just, oh, yeah. So, yeah, hate it.
Right.
That's a
So the net
big,
net there
big,
is
big red
testing,
flag.
yeah, testing, going to an actual endocrinologist, your OB,
Your
working through that together.
internist. Yeah.
Okay,
Yep.
great. Cycle syncing. So this
Yeah.
one actually, I I haven't tried it, but I think I have tried the just for sort of to your point, a test and see case because my nuance is that I have PMDD. I cannot rest in my luteal phase. It is not bode well for me. I need to, if you recall, I'm a big boxer, so I need to go box. I need to do a little bit more high intensity because for me, it helps with my anxiety, my mental health before I get my
Right.
period because
Right.
I really need that.
But what would
Um,
cycle syncing tell you to do?
Stretch, rest, and I would go bananas.
Right.
Fucking bananas. So,
Right.
so I that is not for me, and I think it is not for a lot of women. And I
Yeah.
think that goes back to what we were saying initially of we're grasping for straws because no one told us about our bodies initially. And so we're like, "Oh my gosh, I can learn about my cycle and I can eat all the right things and move my body in the right way and I could feel good." And again, if it's a placebo effect or it is working for you, great.
Yeah.
Awesome. Like if that works for you, that's incredible. Like if that helps you to track in the right way. But I'd love your
Yeah.
expert opinion on that. And then from the nutritional aspect, kind of
I
weigh
think
in.
it's really fascinating. And I love that we are paying attention to this, that we're in
Mm-hmm.
this place where we are looking at differences in metabolism
Mm-hmm.
over the
Mm-hmm.
cycle and really paying attention to the
Yeah.
different phases of the menstrual cycle and how it makes us feel. So that we can adjust. But this idea that sort of everybody should be on the same plan really
Yeah.
doesn't make any sense to me. And it's not really based in science as much as
Mm-hmm.
some people would have you believe that it's really scientifically,
Right.
based and that there's
Mm-hmm.
evidence for it. And that really, really pisses me off is when, people use
Right.
science to back up things that really are not scientific. And
Mm-hmm.
so I would love to see more studies in this space. I mean, it's certainly true, and I've seen this anecdotally, and I've read the studies that there are changes in glucose utilization in different parts of
Mm-hmm.
the menstrual cycle. And so, but for people who maybe have prediabetes, who have PCOS, it may be different from people without. So we can't take what we've learned or the data from normal, healthy, cycling people who are in
Mm-hmm.
their, early 30s and extrapolate that to all women across the lifespan with all different conditions. And
Right.
so that's where it falls apart for me.
Mm-hmm.
And I just feel like everybody's sort of gotten on this same bandwagon of
Mm-hmm.
like one or two particular loud voices,
Mm-hmm.
and it doesn't necessarily apply, right? Like
Right.
you. And then you would go away feeling, I mean, not you, but somebody like you could go away feeling like I'm not doing it right, or what's wrong with me if I feel like I want to be boxing, but I'm supposed to be, you know, not exerting myself as
Meditating.
much in this time,
Right.
then there's something wrong with me,
Mm-hmm. Mm-hmm.
right? So somebody younger or, more vulnerable might feel
Mm-hmm.
that way. And
Right.
that bothers me. For somebody who has, whether they have PCOS or not, but if they have, pre-diabetes, they're going to be less insulin sensitive in the luteal phase. They should
Mm-hmm.
be maybe doing more to
Mm-hmm.
try and address that, to try
Right.
and like they should be moving more to
Mm-hmm.
try and improve their insulin sensitivity. So it really bothers me, and I feel like it can, potentially be, be harmful for some people.
Right.
So I look forward to the day that we really do know more and that we can also learn more person specific patterns,
Mm-hmm.
right?
Maybe we
So
need
that
to create an app or something, you and I.
right? So, using all the different, using our wearables, I love my Aura ring. Using all the
Did you
different
see what they
personal
added the other
data.
day?
Um,
It-
yeah, it doesn't apply to me, but
well, so tell me. So it's tracking perimenopause symptoms, is that
perimenopause
right?
symptoms.
That's
Yeah, I
pretty
think it's
cool.
just going to track the symptoms and track. And it is cool because there definitely are some changes, that occur when I
Mm-hmm.
added oral progesterone to my regimen when
Mm-hmm.
my
Mm-hmm.
sort of Mirena tapped out.
Mm-hmm.
I
Mm-hmm.
noticed a big change in my heart rate variability. I don't really know what that means for my health. I was concerned at first, but nobody could actually tell me if I should be
Right.
concerned or not. That's the
Right.
other thing, right? So I know, more than the average person, and I
Mm-hmm.
noticed this trend, but I don't know if I should be worried about it or not. I'm certainly not
Right.
going to stop taking my progesterone. I need it.
Right.
So
So then what do you do as a professional? What do you do in that scenario? Do you
just keep
consult? You just go,
I've
you just
asked
do
I've
an,
asked some people, nobody has an
yeah.
answer for me, so maybe one day we'll know, right?
So
Maybe
we
we'll
need to
have
do
that
more.
data.
Okay. We need
Yeah,
to
but
get
we
some
don't have
grants out
it.
there.
So we don't know. So yeah, I've asked a few people who I thought would know, and they didn't know.
Oh gosh. Okay. Well, my final two questions for women's health or just health in general as it pertains to nutrition,
Yeah.
because these are also hot button everywhere. Protein and seed oils. I am trying to get in all of the protein. I'm now
Yeah.
18 months postpartum with my second.
Yeah.
And so I'm like, okay, we're getting through it. I'm eating, but I'm now eating like breakfast sausages because I'm like, and then I'm like, oh my God, I don't want to get colon cancer. Like my mind literally just
Yeah.
spirals because
Yeah.
there are so many different things that we have to keep in our brains to figure out in terms of health. And so, how much protein do we actually need? I think we need to offset it with some fiber. So I'd
Yeah.
love your thoughts on that.
Yeah, for sure.
And then we can dive into seed oils.
Right. It's a huge challenge, and it's a huge
Mhm.
challenge, especially for women in midlife, because you do, as you get into perimenopause and menopause and beyond, there is an increase in protein turnover, and so the needs
Mhm.
are increased, but
Mhm.
also your risks of all these other things are increased, right? So
Right.
colon cancer and cardiovascular disease. So
Mhm.
oftentimes increasing your protein needs can also lead to an increase in saturated fat or processed meats, as you pointed out. And so how do you balance that out?
Right.
I think like a mix of protein and animal and plant proteins is, that tends to be my approach. So I'll sort of
Mhm.
double up but not double down on animal protein. I'll try to combine them so
Okay.
that I don't feel like I'm not worried about if I'm only having plant protein that I'm getting all the amino acids, but I'm augmenting with that combo. And that also ensures that I'm getting enough fiber. So that's really been my approach to that. And how much do you really need? It depends on what you're doing, right?
Mhm.
Are we maintaining? Are we recovering? Are we building?
Mhm.
When you're pregnant, you need more. When you're building muscle, you need more. When you're in a recovery phase, you need
Mhm.
more. But if you have a decent lean body mass percentage and you're just trying to maintain, you probably don't need as much as, people are saying. So, um, we're talking about, usually it's in grams per kilograms.
Mhm.
If you're just really trying to maintain, you have a routine that includes strength training, but you're not really looking to change your body composition,
Mhm.
probably 1.2 grams per kilogram is going to be fine.
Okay.
And then these also like insane if you eat, you got to have 30 grams in each meal. And if you don't, and if you eat too much in one meal, you're not going to absorb it. That's also not really supported. If you
Mhm.
do have 20 in your breakfast, but 40 in your lunch, I think you're going to be okay. Right. So this
My
sort
my
of like,
husband was like, because I'll do a workout and come back, and I actually love this brand Teton. They have like these breakfast sausages, and so I'll eat a whole pack. And he's like, "You eat a whole pack?" I'm like, "Yeah, it's like 30 grams." I'm like, "I have to get it in," but then I'm so full, and I haven't had anything to offset it, so I'm just like hammering processed meats. So I guess a question for you is what's like a good balance? Women are also curious about protein powders and amino acid supplements that are now on the market. Is that something that you can also factor in? Like,
yeah.
what's your expert take on that?
I mean, unless you're really vegan, you probably don't need an
Mhm.
amino acid supplement.
Mhm.
Protein supplements can be useful if you're somebody who maybe doesn't eat everything,
Mhm.
right? If you don't eat meat, if you're vegan, if you don't like eggs, I don't like eggs. So sometimes breakfast can be a challenge for me.
Mhm.
Um, and so you can use protein powders to sort of boost up your meal, especially if you're trying to maintain a caloric deficit because you're trying
Mhm.
to lose fat. And so you want to make sure that you're really not increasing the calories in your effort of trying to get all your protein. So you can use protein powders in that way.
Mhm.
Again, good reliable sources. And just stick with the big brands, I would say. And there's different ways. I'm actually going to do for my PCOS community, but it'll be open to everybody, sort of how to use protein powders in
Oh,
food, right?
I love that.
Beyond just smoothies. So
Mhm.
looking at the properties of the different powders and how can you
Mhm.
incorporate them in a way that makes sense from a culinary standpoint.
Mhm.
I'm gonna that's gonna be next week. So
Great.
I'll send out an email
Well, yeah, we'll
by
send
the
it
end
out
of
to
the
the
week.
community. I love
Yeah.
it.
So that is that's interesting. And
Mhm.
there's more interest in, in that.
What
So
what did you have for your protein today?
what did I had Greek yogurt.
Okay.
Yeah. Greek yogurt, some strawberries, and I like to add hemp hearts.
I love hemp hearts.
Yeah. So
Great.
yeah, hemp hearts are a good way to boost some protein. I worked last night, so I've only had one meal today because
Mhm.
I woke up this afternoon. So
How many
uh,
deliveries did you have?
how many did we have last night? Um, one, two, three, three overnight. Yeah,
Awesome.
yeah.
All right, one quick fire round. Are you
Okay,
ready?
I'm ready. Yep.
Okay. If you could redesign medical school from scratch and thinking of women in mind,
hmm
what would you add to better serve us?
Yeah. I think identifying
Mhm.
the sex differences
Mhm.
at each and every level, in every condition from the beginning,
Mhm.
right? And just from the very get go, explaining how this occurs in men and how it occurs in women.
Mhm.
Because we learn really the default, which is essentially the processes in men, and then an
Right.
asterisk for this is how it might be different or present differently in women. And
Right.
so I think just those sex differences really
Mhm.
should be presented from the very beginning.
Great. What's your favorite personal care product? Could be anything. Cleaning, makeup. You could show me that lip gloss that you have on.
That is one of my new favorites, but it's hands down because I was thinking about this. I don't use a ton of like specialty stuff. I try not to like buy too much. It's a prescription. Is that okay?
Sure.
Hands down, my vaginal estrogen.
Great.
Life changing.
Wow.
Yeah.
And tell us
In
how
what
it was
way? I'll tell
life-changing.
you. Okay,
Yeah,
so I'll
tell
tell you
me.
the story. I went. I'm in menopause. I went through menopause
Mhm.
a little bit in the earlier side of my mid 40s due to my endometriosis.
Mhm.
And so I've been on menopausal hormone therapy for a few years, and I didn't think I needed vaginal estrogen because I didn't have any dryness. I didn't have stress urinary incontinence. That's where you,
Yeah.
right? If you cough or you sneeze, you
Mhm.
leak urine. But I was having really terrible urgency. And I've always had some because I've had
Mhm.
some endo on my bladder and it was getting worse. And last summer I was like, shit, I'm going to Morocco for my retreat.
Mhm. Mhm.
And how am I going to manage this, right?
Right.
I'm going to be in another place and we're going to be doing tours and finding a bathroom may not be so convenient. And I was like, I got to do something, right? And I bought
Mhm.
all like incontinence underwear so I would be prepared. And I was like,
Yeah.
but I have to do something. And I had really sort of traditionally learned that vaginal estrogen was more for dryness
Mhm.
or for stress urinary incontinence. And I read somewhere that it could be beneficial for urgency. So I was like, shit, well, let me try it because
Mhm.
otherwise I may need to take like an oral medication and there are side effects. And in 2 weeks, I was like, a changed person.
That's amazing.
Yeah, changed my like really
Wow.
life changing.
That's
And
awesome.
so, and I shared that when I went to the retreat because our retreat is all about
Mhm.
sharing. And
Yeah.
even some of the doctors that are very knowledgeable about
Mhm.
menopause were not so aware that this was an option for urgency. And so,
Awesome.
that really has yeah, that's probably the most impactful thing that
That's
I
great.
have done. So yeah,
I love it. What is one trend you're seeing on social media that is the most harmful to women or that you wish never existed?
I don't know. There's so many. It's really they just feel like they just keep getting worse.
Mhm.
We were talking about cycle syncing and we didn't really talk about contraceptive demonization
Yeah.
in social media that is there.
Mm-hmm.
Um, that there is a lot of language out there around demonization of contraception and around cycle syncing that is couched as being empowering,
Mm-hmm.
but is really disempowering.
Right.
It really comes from a place of misogyny,
Mm-hmm.
of reinforcing traditional gender roles that I think is really super creepy.
Mm-hmm.
And that is one thing that I wish would go away.
Yeah. And it's so, I mean, the same thing is sort of happening with SSRIs right now, pregnancy.
Right.
It's
Yep.
just the fear mongering of, for birth control, of cancer. And I mean, again, going back to my nuance of the PMDD, like my IUD helps tremendously with that and just helping me to regulate. And that's so important. And to your point earlier, I also felt so ill on the pill. I hated it. I tried all of them, but the IUD seems to work for me. I think it's that trial and error. And I think the
Yeah.
messaging can be so dangerous to just get women right off of it, not talk about any of the side effects. And then
And
for
end
the
up pregnant.
right, right. Here we are.
Yeah.
And then here's a stipend. Can
Right.
I say that?
Yeah. No, it's no, absolutely. It's really fucking creepy. It really creeps me
Yeah.
out. And it's so insidious.
Yeah. So anyhow, what was the last thing you Googled?
Um, I've been having I hope they never hear this. My kids are away at camp,
Uh-oh.
and I am missing them. I really am. But I was Googling real estate, looking for small seaside condos, like a
Oh.
studio or a one-bedroom, really just for myself.
Okay, any real estate agents, listen up. Where are you looking?
I can't afford anything right now. I have 2 kids that are going to college in 4 years.
But
But
where do you
this
want
is
to
just
be?
this is just fantasy. In my fantasy life, I have a place where I go by the sea just by myself. No husband, no kids, just my little seaside escape. So that's really the
Well,
last thing I was Googling this morning. So
that's a great segue into where we can find you, because I do know that you have a retreat coming out in Morocco. Perhaps that could be your little
yeah.
faraway
Oh, that
sanctuary.
is my faraway sanctuary. I'm so
Yeah.
excited. This is going to be our second retreat. It's the Love and
Mhm.
Nourish retreat, um,
Mhm.
co-hosted myself and Dr. Sada Floaty, who's just brilliant expert in menopause and sexual
Mhm.
health.
Mhm.
And it's hosted with Carrier Retreats, and it's going to be in Marrakesh and Essaouira in
So
September.
amazing.
And we
Mhm.
will be announcing and opening our 2026 retreat for registration in the next, around the time of our next retreat. So,
Amazing.
yeah, so, just look for us sharing all about the retreat,
Mhm.
and we'll share how you can sign up for next year. We
Great.
sold out for this one. This is only our second retreat. We sold out for this one in January. So,
Amazing.
yeah, because it is amazing. So,
Yeah. So
yeah.
where can people follow you
So
on
you can
social,
follow me.
everything?
Mostly I
Mhm.
post on Instagram, so you can find
Mhm.
me, Dr. Basma Faris,
Mhm.
DrBasmaFaris. Also, drbasmafaris.com, so you can sign
Mhm.
up for my newsletter and learn about all the webinars that I do. So, like the the protein powder one that's coming up, but I'm doing, I do monthly webinars, and yeah, and just follow
For all of our
along.
PCOS girlies, they can
Yeah,
go on your site
PCOS
and
and
yeah.
other, mostly PCOS, but
Mhm.
um, yeah.
I love it.
And hopefully I'll be back. This was great, and then the time went so quickly, so
Yeah. Thank
we'll
you
have to
so
do part
much.
2.
You are just such an incredible woman and an inspiration. And thank you so much for coming on.